On popular demand, we have you back here at ACC to answer some questions.
I'm like the bad penny. I keep turning up.
So, people are really interested in this topic of microcirculatory dysfunction. One of the questions that we've gotten is, how do we treat this patient?
That's a great question. And I think that we actually had a lot more confusion come into the realm with the Warrior trial. Our approach certainly is going to be a full diagnostic assessment. And so that's why I think the full, whether it's thermodilution, Doppler, however you're assessing the microcirculation, CFR, some type of resistance, and then spasm testing. From there, we can then more individualize the treatments and therapies. So hopefully that, if we are seeing spasm, then it's more of a nitrate calcium channel blocker. If it's not, maybe it's an L-arginine, lifestyle modifications. We're looking at EECP, we're looking at coronary sinus reducers, but knowing the endotype is going to be important to treat.
We touched on this briefly last time. So for communities that don't have access to the advanced testing that you do, what would you recommend?
So I think you can do a couple of things. You can always refer. There's a microvascular network website that has all of our sites on it and has contact information. I think that you could reach out to the individual cath labs themselves. You can reach out to some of the experts. And the other thing you can do is, if you do have a normal CT or a normal angiogram, see what you have in your cath lab. And usually everybody has some type of physiology and imaging. At least look for, the myocardial bridge. At least look for some of the abnormal resistances and start there and see if you can at least start to individualize therapy from there.
What is your biggest takeaway from the Warrior trial that just came out here at ACC this year?
Stepping back, it was supposed to be, 4,000 patients, all women, Department of Defense, largest women-only trial in the United States. So a bold endeavor. It was somewhat derailed by COVID. They just couldn't get the enrollment. But the problem is they just had to have a normal CT scan or angiogram. So there was no endotyping of what microvascular dysfunction they had. And so they were just placed on either high-intensity statin, aspirin, and ACE or ARB, and versus usual care. So because there wasn't the individual endotyping, I don't think that we were able to really understand the ramifications, because there were no difference in the outcomes after 2 to 5 years.
And so one of the important takeaways then is that we need to learn more about these patients with more strict endotyping and really individualizing patient care for what we learn in the cath lab.
Agree.
So we have a lot of people who are not part of cardiology, but in primary care and other specialties, who have heard microcirculatory dysfunction for the first time. For people that don't necessarily do the things that we do in the cath lab, could you explain what that means? What is microcirculatory dysfunction?
We're from Texas, so I use I-35 as sort of the example. And if you think about, when we look for usual cardiac chest pain, shortness of breath, anginal symptoms, we think about the major artery being blocked or occluded. We relieve that occlusion, the blood flow goes, and everything works well. So that would be like I-35. If there's a wreck on 35, you clear the accident, traffic starts to flow. Well, what happens if you just close down all of the exits? Traffic on I-35 is still going to flow, but nobody's going to get to the destination. So the blood cells still don't get to the myocardium if the small vessels don't work. And so we're seeing the 15% of the vessels with the angiogram, with the CT, that look normal, but really what lies beneath is where the problem lies.
That is such a beautiful example, and I will be stealing that for my own use with my patients and others. And I think it also shows you, not all patients are the same. Just because you have an angiogram report that says no obstructive atherosclerosis involving the epicardial vessels, it doesn't mean that the patient isn't suffering from some type of pathology. And so
Agreed.
Always keeping this on our radar, always asking questions, making sure that we find the right people to help.
Agreed. Also important is the negative test. So when the test is normal and we know that it is not microvascular disease, then we can get them to the GI doc or the pulmonologist or wherever else to get them to feeling better.
And so an angiogram without further testing is an incomplete test in those patients.
Exactly.
Because we can either include or exclude.
Agree. That's going to be an insufficient diagnosis. We need to dive deeper. We need to take a closer look and really get the patients the best care they deserve.
Okay, this is actually personal interest question. So how do we get more interventional cardiologists to become comfortable with doing microcirculatory testing in the cath lab?
One of the things is going to be just making sure they understand the physiology from the get-go. And it's really not hard. It's 3 variables. And if even I can understand it, then I promise anybody
Well, you're
can.
the person who teaches it.
It's not very hard, as long as we understand pressure, flow, and resistance, and sort of how those all intertwine. So if you understand that, and if you're working up a patient and you see a gap somewhere in the physiologic parameters and the symptoms, then I think that's time to go deeper. And why wouldn't, as interventional cardiologists, we want to do more stuff? It's an opportunity to do more stuff and to get the diagnosis. So why not?
And the technology itself is relatively safe, right? As long as you use good technique, good practice, understanding that every time we do something invasive, there's always going to be a risk. But the benefit is in how we treat the patients.
Absolutely. Thousands and thousands of patients, very, very, very small complication rate, including the wiring, the catheters, the acetylcholine, everything else like that. Very, very safe when used effectively. And if there are great programs out there for proctoring as well. So if you want somebody to come and watch you do a few or watch somebody else in their cath lab see their flow, those are widely available.
So would you consider doing a part 3 where you teach us some more about microcirculatory testing in the cath lab?
I would be honored to do that.
Excellent. Stay tuned for more.